Okay, thank you very much for joining us today. So I've just got a couple of questions regarding our Cancer Awareness Week that we're going to be holding on the CYPStNN network, which is on Twitter. So my first question for you today is, what or who inspired you to become a nurse?
Well, I guess I'm probably one of those people who it was just a vocation. So I think, right from childhood, I literally had dolls lined up in a row, usually covered in felt tip spots, bandaged up, really that kind of thing. Um, Probably quite inspired by whatever nursing stuff was on TV as I was growing up. There was a drama series in the mid-70s called Angels, of all things, about student nurses, and I used to follow that avidly. Um, I think as well, I was in the British Red Cross when I was a teenager growing up, and you could do a lot of courses through the Red Cross. So they had sort of three basic courses: nursing, childcare, and first aid. And you can do those at basic level, and then like take a second level. And if you got all six, you got a little proficiency medal. So I did all of that stuff.
Brilliant.
A lot of my weekends as a teenager, I was doing first aid duties at things like the roller skating rink and local football
Oh,
matches and some quite bizarre things. So I used to go to an annual Morris dancing
oh.
championship for first aid and badminton horse trials and local country and westerns. So yeah, all good preparation though for working with the public, and I think probably continued to steer where I went later.
Yeah, definitely. And so whereabouts did you study?
Nurse training for me was absolutely always in my plan. But in my final year at school, we had a careers talk from a lady who came from the army to talk to us about female military careers because I went to an all-girls school. And she kind of was asking us all what we wanted to do. And I said, oh, I'm not interested in the army because I'm going to be a nurse. I was really, that's what I'm going to do. And she's like, so come and be a nurse in the army. And then kind of told us all about nursing in Queen Alexander's Royal Army Nursing Course. So she hooked me in straight away, really. So I joined the QAs in 1983. Um, you do your basic military training first, then you do 3 years nurse training. And at that time in the 1980s, we still had military hospitals in the UK.
Yeah.
And so as well as moving wards, you could also, I also did move locations. So I worked in the military hospitals in Woolwich, Aldershot and Catterick, which in itself is quite funny because the adverts at the time would join the army and see the world. So I saw a lot of England, and the other half of my group went to Intel in Germany and Hong Kong, but I'm not
Oh.
bitter about that. Um, so I qualified as a registered general nurse, first of all, through the Army School of Nursing. Um, the syllabus was the same as for NHS nurses, and we did placements for things like midwifery, psychiatrics and geriatrics in NHS hospitals.
Yeah.
Really, really enjoyed my army career. Still got loads of close friends from that time. But I definitely enjoyed my paediatric placements, and I wondered then about doing my registered sick children's nurse training. But I wanted to get some experience under my belt first, really, before I made that move. So
This is a add-on question that I've just thought of. So,
yeah.
in terms of the military hospitals, my complete lack of knowledge and understanding of that whole setup, layout, etc. Could you expand a little bit more?
Yeah, I could, and sadly, we no longer have military hospitals
Yeah.
in the UK anymore. But yes, so I think they were. I don't think we did we have any more than those three at the time. But absolutely fully running hospital. You were nursing the soldiers, obviously, but also their families. So we had gynae and we had paediatrics and all of that kind of thing. And I can't remember what the percentage was now, but we also had to take a certain percentage of the local civilian population as well. So you
Yeah.
got all of the local things. So we had a really good sort of rounded training, and so it was the same syllabus. So
Brilliant. Thank you. So what was your first newly registered qualified role? that you had?
Yeah, so again, things are a bit different than if you take an army career route,
Yeah,
because it's not like the challenges you face today of going looking for your first job when you qualify. So we were just allocated to the areas where we'd be working, and that could have been any specialty or anywhere in the world, although I stayed in England. So I worked in ITU for the first few months of my career, really enjoyed that. Then I was moved to female surgery, which also had an ophthalmic unit attached to it, so you might be rostered to the surgical ward or to the ophthalmic annex. All of it was great experience and excellent training in the army. Not everybody's cup of tea, I have to say. Matrons rounds with the colonel were utterly terrifying.
I can only imagine.
Yeah, absolutely. And you really did have to know everything about every patient, and you had to take around bed by bed and explain everything, but it was good. It was good. I guess then by 1987, I'd had a shoulder injury, which meant staying in the army and maintaining the fitness levels that I needed were a challenge. And I'd really by that time decided that I wanted to do paediatrics long term. So I applied and was successful to do the RSCN conversion course in Birmingham. That was through the Queen Elizabeth School of Nursing in Birmingham. And I went for the interview for the course, and the interviewer suggested that I did 3 months working on a ward to kind of get used to NHS ways of working, because I'd been in the army.
Yeah.
And I didn't really want to defer my course. I wanted to get on with things,
Yeah.
but it seemed like that's what they were offering me. So I just was like, yeah, that's fine. And then they kind of then whispered in a really odd way. They said, would you mind working on the immunocompromised ward? And kind of, I was just like, yeah, I'll work wherever you want me to, because, you know, in the army, you went wherever you were sent. So I was kind of used to that. That was
Yeah.
okay. And then I went home and looked up immunocompromised, because I actually wasn't really quite sure what they were talking about. And it was the mid-80s, so it was at a time when a lot of boys with haemophilia had contracted AIDS through the blood transfusions.
Yeah.
And from what I was reading, I was kind of gathering that they were immunocompromised through their treatment. So I kind of went to work on my first day kind of thinking it was probably something to do with HIV and haemophilia, because of the way they'd whispered it. So I arrived on the ward for induction, walked on to a ward full of bald-headed children with cancer. And I was like, wow, it's a cancer ward. Oh, that's probably why they said it like that. Oh, children get cancer. Yeah, well, I guess they must do. Hadn't really ever thought about it. And I have to say, within about 2 hours, you know, by mid-morning on the ward, I was like completely sold. It's like, this is what I want to do forever. Can't imagine ever doing
Give me
anything else.
shivers.
Yeah, it was fabulous. Loved it. You know, I mean, I think what I found immediately was a fantastic team of nurses, a great way of working together, amazing specialty, and just masses to learn. I knew, like, I'd enjoyed ITU, but again, I got the sense this is something you could really get your teeth into and become a real expert at. So, and of course, then I had to leave and do the course, which then having not wanted to
Not
not get
wanting
on
to
with
be
that,
there to
I had to
start
get
with.
wrenched away from oncology to go and do the course. I went straight back. So,
Brilliant.
so yeah, for their kind of work through the grades on the ward, I did about 7 years at different grades in the inpatient ward. Then I moved to being the manager of the daycare unit, did that for about 8 years, and then I got the lead cancer nurse role and did that for about 12 years in Birmingham. And that role was a brilliant role, because that really was a combination of strategic work, but I also maintained 2 days as an advanced nurse practitioner in daycare. So really that role gave me the opportunity to work on a more regional basis, get involved in some national projects, and give me that really good understanding of cancer services in the UK, the whole breadth of things. So by the time I'd done kind of 25 years at the Children's Hospital, I wasn't particularly looking for a change, but an opportunity came up that moved me in a new direction. So I thought, yeah, okay, I'm ready for a new challenge now. So I moved to the children's charity Click Sargent, which is now known as Young Lives versus Cancer. So that was kind of that first bit.
Brilliant, thank you. So what is your role now? So you've kind of led us to there where you are now. So tell us more about your role.
Okay, so my role now, I'm currently the Chief Nurse at CCLG, which, as I said in the intro, stands for Children's Cancer and Leukemia Group. So that's an expert professional body for people working in the fields of childhood cancer. It's the paediatric special interest group within the Royal College of Paediatrics and Child Health. And it's a membership organisation. It's also a charity. I've done a resource sheet for you, and I've put links to CCLG in there so that students can pick that up. So CCLG brings together all the professionals that work in childhood cancer, nurses, psychologists, clinicians, the scientists, the researchers, all together in one organisation to kind of really work together to improve treatments and patient care. Obviously, the aim to cure as many children as possible, but also trying to reduce the side effects of treatment. We also fund research. We advise the government on matters to do with childhood cancer, and also provide kind of award-winning patient information for families affected by cancer. My post is still funded by Young Lives versus Cancer, where I went to first, and they provide social care support for families affected by childhood cancer. They also provide a grant service to help with the financial cost of cancer, and they provide home from homes near to some of the bigger centres so that the families can stay near their child if they're in for a long time. So my role is actually across both organisations, and I'm conscious that I'm giving you and the group lots of new information, so let's try and kind of simplify some of that in a bit. So in essence, think about it like this. So CCLG are the clinical experts in childhood cancer care. Young Lives versus Cancer are the social care experts in childhood cancer care, and actually my role is about bringing together the best of clinical care, the best of social care through a nursing lens. So what I do is I gather insights from both organisations and share them from the NHS and all of my contacts and links there. So it's all about gathering insights around childhood cancer so that both of our organisations can influence good practice, well. And that takes that right from the bedside, sort of influencing good practice at the bedside, right through to, as I say, informing government policy on what they need to know, and that's for countrywide, and to some extent a little bit of contact with Ireland as well. So
very vast and very interesting role, I imagine.
Yeah, it's quite different.
Yeah, brilliant. So what does your typical day look like then in your role? Describe as your typical day. I bet they're none the same. I bet they're not.
No, so I've kind of pulled together a few examples really. So I guess most of the time I'm working with other teams on specific projects or activities, things that are important to improve the lives of and experiences of families. Of course, kind of post-COVID, a lot of that these days happens via the computer and email and Zoom and Teams and all that kind of thing. But pre-COVID, I did get out and about into hospitals, and I'm not sure that we'll ever quite go back to that. So picking out a few things that I get involved in. So last week, for example, the Manage Scotland network, which is the cancer network for children and young people in Scotland, they just launched their consultation on their latest cancer strategy for children and young people. So my role will be about when there's a consultation out like that, reading the document in detail, drawing on my experience, pulling out the resources from the organisations that I represent, thinking about whatever evidence we can provide to respond to that consultation. And sometimes that involves giving feedback on the things that we know are important to families from the work we do with them. And sometimes it's confirming that we agree with what's in the strategy so that they can say to their policymakers, CCLG agree, Young Lives versus Cancer agree, because that's important. but also looking at whether, you know, the priorities are kind of right, it's weighted in the right way. And if in a strategy, for example, they've highlighted things that that are maybe a known challenge for them, looking within our organisations or around the country and providing some feedback to them on how, you know, there are other people around that we know that might have, you know, resources or people or projects that could help inform that. So I guess that's kind of one example. And similarly, I can't speak now. Similarly, the year before, no, earlier on this year, I think, in fact, I was working with the Northern Ireland teams on their first Children and Young People's cancer strategy. So that was inputting at an earlier stage than the Scotland one, where they're trying to just gather that evidence and information in the first place. And that consultation is due out later this year. So that's kind of consultations broadly, quite a few of those. I often provide kind of project management support to national projects, so where that's informing good practice. So again, I put resources to this in the list, but we worked on a telephone triage toolkit for children's cancer services. So that's to make sure that when families ring into a hospital, they're getting a consistent evidence-based assessment that triages them in a timely way, right place. It's about making sure that everything's documented accurately and quickly, so there's a format that enables that to happen fast. And then there's an audit trail for the call, because, you know, before we had this, actually, there were very often, it was in the head of the person who took the call, that kind of thing. So that piece of work helps improve safety for families and staff, actually. So yeah, that's a typical example of projects. I'm working at the moment on updating the RCN career and competency framework for children's cancer nurses. So it's core competencies really for nurses who might encounter a child or young person with cancer in any setting. I mean, predominantly, obviously, it's you know, for children's cancer inpatient wards and daycare and all that kind of thing, but also thinking about students on placements, so including competencies for that, so that document informs the health, the higher education institutions, so they know what kind of content to put in for you. So also this time, for the first time, including nursing associates and what competencies they need. And then general nurses who might have contact, so kind of thinking about the unwell child that comes through the A&E route, or you know, very often when there's capacity issues on wards and you've got oncology children outlined on other wards, so what do those nurses need? So that kind of thing, and that kind of piece of work, that obviously there's the project work and getting that document updated and doing things, but it's also linking with other people. So the adult cancer services are doing a similar update to their document. It's making sure we're kind of mapping things together. So
that's important too, obviously, because children do become adults, don't they?
Yes.
So that transition and consistency through services, etc. So
really important. And for the TYAs, they could be in a TYA specific unit, but that might be within paediatric services, or it might be within adult services. And so there is a TYA set that complements both. So it's about having that pathway all the way through.
And so important, obviously, keeps the child and the family at the centre, really, doesn't it? So
absolutely.
Lovely.
So I guess other things then, kind of in the day job, I provide advice to young lives versus cancer, you know, on a as and when basis, what they need. And that might be social workers contacting me about a referral they've had, not sure if it's cancer or benign tumour, and if it, you know, or if it's not really related and they shouldn't take it. So that's basic information, finding out about the disease and advising them. Last year, obviously with COVID, I was quite involved with our home from homes and making sure that they could stay open safely, because it would have been really difficult for the families if we'd had to close them, but we needed to do that with all the usual, you know, safety measures that we're putting in place, but getting that balance right between putting enough measures in to follow the government guidance on what was happening in the wards, but also keeping that home feel. So what's the balance between what we need to do clinically and what the homes feel like? And then I attend national NHS cancer charity meetings, all that kind of thing. And that's really important because often the national policy picture for cancer, because the numbers in adult cancers are so fast, sometimes policy can be really good to that, and you need to be there as a voice, reminding people about children's cancer services and speaking up for what the families need. Recently got involved in the first ever under 16s National Cancer Experience Survey. So again, that's something that was provided through NHS England for adults with cancer for years. But you know, despite everybody asking, there wasn't one for children, and lots of campaigning from NHS colleagues and the charities. So the first one has gone out. So the data collections happened in the summer. And the report will come out later in the year, so that's exciting because that's new. And then I guess,
so from those experiences, is it seeing how they feel their treatment's been, or hospital intervention, or just the whole experience of that child with cancer and their families, and then would that help guide practice changes? Or
that's the aim. I mean, you know, I can't, off the top of my head now, I can't remember kind of the detail of the questions, but it is asking them about, you know, sort of how they were told, what their services are like.
So it goes right from the start of
all about their care really. And then so the bit that I'm involved in now is what the report looks like, so that there'll be a kind of version for families that have taken part, so that they can understand what came out of the survey and what's going to be done about anything. And there'll be versions for the NHS. There'll be a big report that looks at everything collated, and then there'll be individual reports for trusts, so that they can see their own local details. Obviously all anonymised and all that kind of thing, but local trusts will know if there are things in their themes within their service that they need to know about. So that's good.
It sounds exciting.
Yeah. And then, you know, kind of networking wherever I can, really, just to keep myself up to date and make sure that I'm representing the organisations that I work for well. So yeah, I think that's enough about the day job. Gives you a sense of how I'm spending my time.
A lot of variety. So can you share a memory from your career with us which you are most proud of?
Wow, I think that is the hardest question, to choose one memory. And I would say, is it a cop-out to say the whole thing? My whole career has just been the most wonderful memory that I'll always be proud of, and kind of just picking out some highlights from that. I've been really privileged to have some fabulous opportunities, you know, been in the right place at the right time a lot of the time. I've been able to apply for ward charitable funds for additional education, and that's sad that we have to go down that route, but actually that's helped my career. I've had brilliant managers and employers along the way, some that gave me a lot of freedom to be creative and try things out. But if you take it down to kind of, you know, the really day-to-day level, I'm really proud of every time that I helped a child or a parent feel safe when they were going through kind of their scariest moments. I'm proud of opportunities to help educate others and share my experience. Proud of resources and guidelines that we've produced over the years that help improve how something happened. I did a piece of work with the hospital chaplains in Birmingham, actually, about thinking about spiritual care within the department. So, you know, whether families are religious or not, and even if they've got an out and out rejection of faith, cancer has a spiritual element to it. It makes you think about your life, its purpose, if it's going to be long or short, about death and the manner of dying. And I think compassionate care in cancer, it isn't just about compassionate nursing, it's about showing families that you understand that this is hurting something deep in their soul, because it really does have that kind of connection, really. So I'm proud of publications that I've had. I'm proud that I was the first advanced nurse practitioner in paediatric oncology in the trust where I worked. There was another advanced practitioner before me, but actually her clinicians weren't as forward thinking as the oncology ones and kind of inhibited a little bit. So I was claim that I was the first one to
Go
get it
for
off the
it.
ground, to go for it. And I was also the first nurse prescriber, and I was the first nurse prescriber in the trust. But actually, I'm even more proud to see where the generations that have come after me have taken those roles now and evolved them on from, you know, some very primitive beginnings, and what I thought was really quite exciting is now very mundane. So yeah, but yes, I would say there is so much, the whole
It's
career. Yeah.
Yes, I would back you up on that one from what I've heard just speaking to you now. So yes, definitely. Um, so what is the most challenging part of your role when working with children, young people, and their families?
Yeah, I guess it's kind of quite hard for me to answer that now because I don't provide direct care these days. But thinking back to what was most challenging in clinical practice, I think, you know, often it was time pressures, and feeling like you want to do more.
Yeah,
But you've got to be realistic. You do the best you can. It's good, solid nursing care is what you're aiming for. On the days when you can do more, that's great. And on the days when you can't go the extra mile, don't beat yourself up about it, you know. So yeah, but time pressure's always the biggest challenge.
so we mentioned students a bit earlier. So how can students prepare for a placement within haematology or oncology areas?
Yeah, so this is a great question. I love this question. You know, pediatric oncology sounds like a really highly specialised alien world, and in some ways it is, but I'll come back to that point in
Yeah,
a minute. But I think first and foremost, it's about really good basic nursing care. So kind of number one, assessment and observation. You don't have to be an expert specialist in the field to be really valuable as a student nurse in the team if you're good at observations and observing. Recording accurately and reporting is crucial. And these days, lots of that's a lot easier with Pew's early warning scores
yeah.
and, you know, fancy charts and everything that we didn't have years ago. You had to do it in your head. Um, but yeah, trust in your instincts to really kind of look and listen to the person in front of you, whether that's the patient, parents, siblings, colleagues even. And obviously that good nursing care extends to good mouth care, skin care, hygiene, nutrition, fluids, care and compassion, all that kind of stuff. So there'll be experts around you to deal with the complicated stuff. So kind of don't be frightened going to an oncology is what I would say. They know about the chemo, the IV meds, the treatment regimens and protocols. So students that provide good, solid basic nursing care are really valuable in the team, and you as a student will learn a lot through doing that. I think as well, communicate well, and you know, that's not as easy as it sounds, is it? But you know, check the information that you're given, check you've got it right, you've understood it. A clinician once said to me, everything you do after your first thought, always say, why might I be wrong? And I love that. That's a really good thing. You know, check your assumptions and all of that kind of thing. I think I would say to students and new staff coming into oncology, don't be scared that you won't know what to say or that you're going to say the wrong thing. That's most, if you talk to most people, it's like, oh, I might say the wrong thing.
Yeah, I'm
But
with you on that one. That's one of my
yeah,
biggest worries
yeah,
of what if I say something wrong?
yeah. Um, nearly always you won't actually, but if you focus more on listening to them than trying to think about what you can say to make it better,
Mm,
um, you won't go far wrong, because actually this is a bad situation to be in. There is nothing that we can say that's going to make it better,
yeah,
other
yeah.
than getting their child better, you
Mm,
know, or making the experience as good as we can be. Um, if a parent is tearful, that's normal in this situation, and don't automatically think I must refer them to psychology, because actually they're doing what's normal and it's
yeah,
okay. So you know, I think take time to listen, ask them about their feelings, ask them what they're thinking, ask them who they've got around them supporting them. And then you can do things like checking out that they have been referred to Young Lives versus Cancer Social Care Service, because they can help support with things like coping strategies, helping with practicalities like talking to employers for time off, managing finances, accessing grants, coping with family life, that kind of stuff. But then in terms of the ward and clinical situation, get that, you know, if somebody is really upset and you think they need some more help, get their permission to share that information with other members in the team and get that kind of whole team approach as to how it's best to help. And lots of the senior staff in the department have done things like advanced communication level training. Some of them, a few might have done basic CBT. I think there's a course called Sage and Time, something like that. Level 2, level 3 psychology support. So yeah, I mean, I think listen, get permission to share, pass on the information and document well. And as a student, you won't go wrong doing that kind of thing. I kind of moved on then to thinking about, you know, what you might want to do in terms of reading to prepare.
Yeah.
So I would definitely recommend CCRG do a book called Children and Young People with Cancer, a Parent's Guide. And because it's a parent's guide, it's easy read information, it covers a lot. So that would be my first go-to for students. Then take a look at something called the Outreach Information Resource, which was a collaborative project across the country. It's badged by what was ClickSarge and CCRG, and it's on the CCRG website. So that covers kind of almost everything you need to know about childhood cancer, from can you have a PET when you've started chemo to cytotoxic therapies. It really does cover everything, and it's in really small bite-sized chunks at foundation level, because it's aimed at people who are new into the specialty, or maybe community nurse who is quite rural and sees a child with cancer once every blue moon, just needs something quick to kind of just refresh. So that's what it's for. I've pinpointed within that, within section 7, I would suggest looking at the febrile neutropenia section. So it's pretty important that people understand that when a child's treatment lowers their immunity, they're more at risk of neutropenic sepsis. And obviously all the principles that you've probably learned through sepsis 6 and stuff like that on the wards apply, but children with cancer don't have classic signs of infection because they don't have the immune system to produce pus and all that kind of stuff. So you need to learn that bit about it a little bit. So yeah, I would say a bit of a refresh on neutrophils and febrile neutropenia, but it's all in there, and it's all in there in easy read format. But you know, if you don't get time to read it before you go onto a ward, that's great, because I'm sure they'll give you a session on it. It would be absolutely, it's kind of one of the main things, really. I think on placement, learn as much as you can. If you don't, you know, if you're on a placement and you don't stay in that field, you'll learn a lot of really good stuff in oncology that you take to other places. And then I think, you know, try not to going back to the kind of alien, highly specialised side of it. Don't be too phased by that. I think what often happens is people think, oh, I know a bit about cancer. You know, I've had relatives or whatever. But you go into the oncology ward, and in adult cancers, most cancers named after the body parts, so you know, breast, bowel, gynae, and you've got a bit of an idea of what's going on, really, haven't you? You go into paediatric oncology, and the names of the cancers are named after the tissue that's affected or the person who discovered the disease. And so you get things like neuroblastoma, retinoblastoma, primitive neuroectodermal tumours, Wilms tumours, and you're like, okay, I don't know what any of this. And then the medicines that we use in oncology are not like the things that you'll have found before. So, you know, cytotoxic treatments and immunotherapies aren't often used in other specialties. They are in some, but not often. And adding to that, it's a specialty that uses masses of acronyms to kind of just little codes for what all the different drugs are and how they're grouped together. So you sit in handover the first few times, and it feels a bit like you've been dropped into a foreign language ward, and you can kind of get the patient's name and how old they are, but beyond that, it's all a bit of a blur. You know, but I think what I'd say is, I'm not connected at that ward level anymore, but there was always good student support. There were crib sheets and, you know, things to explain things, and you get some sessions while you're on the ward. And for anybody going into it, you know, it takes a long time to settle into oncology because so much of it is a bit different to everywhere else. But once you've got it, once you know the disease names, once you've got the drug names, and once you know the acronyms, actually, it's remarkably routine for the rest of your career, kind of thing. You know, things constantly evolve, but yeah, it's a massively rewarding specialty to get into. for me, it always felt like the place where I could really use my nursing skills to the best of my ability and make an awful situation bearable. That's possible. So yeah.
Lovely. So this kind of leads on as well from the previous question. So what is the one thing, I'm sure there's many, but students could do when caring for children, young people and their families where there is a diagnosis of cancer that would make a difference? I think you have kind of said it a little bit previously, but if you wanted to expand any further.
Yeah, sure. I can definitely expand on
I
that
thought
a bit. Yeah. Yeah. So I think, the one thing is show your care, but don't be overly gushy. So I'll kind of explain what I mean by that. This will make you laugh because teenagers call nurses and health professionals like that, who are a bit too gushy, they call them head tilters. And they say they're the
Okay.
people that go, "Oh, how are you today?" And they say they feel like they're a lost soul, like give up now. So they want health professionals to give them the confidence that they need. So I'm going to expand on that again, really. So I was invited to write a chapter of a book in 2018, and the chapter was called "What Adolescents and Young Adults Want Health Professionals to Know." So although it was about adolescents and young adults, I think the same applies to children and parents to some extent. And there's this little pop-out box on one of the pages, and it's called "This is what I want health, social care and education professionals to know about how to interact with me." That's just a little table, and I think this little box is probably that one bit of information kind of thing. So the first one is trust, and it's just a little sentence where they said, "I've entrusted my life to you because I have nowhere else to turn." And it's really important to remember that they didn't choose to be in this situation, and they have to trust the health professionals that are looking after them, because actually, if they don't, realistically, there isn't anywhere else to go, and you're talking about their life. So actually that trust is really important. The second one in the list was "Communicate with me and with other people in the team so that I feel safe and I know that you all know what's going on with me." And that was important for them. The third one was "I am not my cancer." So that was "Support my efforts to grow, believe in me. Being different doesn't equate to being less. Discover my strengths and help me use them to overcome my challenges. Sometimes I'll need you to be brave for me or to help me find the courage I need." So that was a good one.
Yeah.
The next one was "Humanity." So this was "Show me the person you are and get to know the person I am. Be kind and friendly, but retain your professional boundaries."
Yeah.
And I thought that's great. So every interaction counts, is what they said. And the last one was "Tough love." And they said, "I may have cancer, but sometimes I need a push in the right direction." So yeah, that came from adolescents and young adults themselves. Like, it's a pretty good guide about how to interact with people with cancer.
Definitely agree from just the little that I've heard there. Yes, definitely. Just some of those spark thoughts in your head, don't they, and stuff
Yeah.
of like how you can relate it to yourself being on those wards and in that situation of, yeah, they are a human. They're not just the cancer that they've got diagnosed. Like they are someone,
Yeah.
kind of thing.
Yeah.
So brilliant, thank you. So can you tell us about a time in your nursing career that was difficult?
Yeah, I think the most difficult thing that we ever went through as a team was actually the suicide of a much loved colleague. It was absolutely heartbreaking. We didn't realise she was struggling, and I think it changed all of us in some way. For my part, it made me better at trying to notice my colleagues more and really encouraging that philosophy of "it's okay not to be okay." At that time, that mantra is a bit of a more recent thing. The recognition of mental health and emotional needs of health professionals really was a lot less recognised at that time. But I think that may be a positive thing that's come out of the pandemic, that hopefully we're taking better care of each other. So Yeah.
And then, can you tell us about a time in your nursing career that gave you joy? Every
Yeah,
day.
again. Yeah, every day. Yeah, not every day. No, there were some
No.
bad days. Yeah, I mean, so many things here. I can get silly and go syringe water fight, but don't tell health and safety.
Love that.
You know, things like just children laughing and having fun on the ward, racing around on their trikes with their mums trying to keep up with the drip stands, coming and pulling, like pressing their nose on the glass door of my office and giggling and running away. I think things like there's one boy who's in my head straight away. The day that he got his cannula in under 2 minutes after months of him working really hard to overcome a needle phobia.
Quite a moment, I imagine,
Yeah,
for
absolutely,
everyone
and
who was
him
there.
feeling so proud of himself. You
Oh,
know, and he really had a terrible needle phobia, but he ended up being a child who helped other children with their cannulas, which was brilliant. I think a new mum bringing her baby to the follow-up clinic and then her laughing with me about when she was told that her treatment could make her infertile. She was absolutely devastated by that, and it was a really tough time for her. And we had quite a lot of, you know, those deep, in-depth conversations you have in the middle of the night on a night shift, because in her culture, she believed that if she was known to be infertile, it would make her less desirable for marriage. So yeah, her coming back with her happily married baby boy was wonderful. And then I think, you know, as daft as it sounds, I'd actually put the invention of ondansetron, anti-sickness medicine, into that list. And that sounds really weird, doesn't it? But that
Tell
drug
me more.
changed. That drug absolutely changed kind of what happened in oncology. And we've still got a long way to go to combat severe nausea and the occasional vomit, but that was a game changer in stopping the incessant distressing vomiting that I saw in my early days. You know, you would walk on and some kids would have a vomit bowl under their chin and they would be vomiting all day long. And so it was a game changer. And actually that's great.
Sounds it, yeah. And then a little bit into so how do you see the future of children and young people's nursing in regards to maybe the advances of oncology care and the treatment of those children and young people?
Yeah. I mean, I think, you know, oncology nursing is going to remain one of the most rewarding careers any nurse can have. I'm sure there are other specialties, but I think it's the best. It's always cutting edge. It's always kind of pioneering new ways to do things. It's an amazing teamwork approach. Nursing is very respected in oncology, and you're real partners in the care with the medical staff, with the whole team, allied health professionals, and with the patient and family. And I think that's another really magical bit of the specialty, the way that it is all about them. There are great opportunities to super specialise. So, you know, not only can you be a specialist in oncology, but you do advanced practice, stem cell nursing, clinical trials and research nursing, palliative care, outreach nursing, practice facilitation in that kind of field. So all of those. I think the whole team of researchers and scientists who are constantly looking to improve cure rates, but also to find kinder treatments to reduce the toxicity and limit the long-term consequences of childhood cancer. There's a lot of hope at the moment in the growth of immunotherapies and targeted treatments. So I think we'll see a lot more of that kind of treatment in terms of the reduction in toxic therapies, which is good. Surgical techniques are kind of constantly advancing because they're using more state-of-the-art scanning and imaging techniques while they do the surgery. So that helps with the complex surgery. We'll see the opening of the second proton beam centre in this country later this year, so that'll be in London, and that means that the families won't have to travel to Manchester or abroad for that treatment.
Which is
And
going to be a
again,
big thing for a lot of families, that
It
is,
will.
isn't it?
Yeah, it will. And that's another way, you know, I mean, that there is definitely still a role of photon therapy, kind of standard radiotherapy, and proton therapy isn't magical. There are still side effects with it, but it does get us a bit further in trying to reduce the long-term late effects. I think we also do need to get better at diagnosing childhood cancer earlier. So over the next couple of years, there's a professional and public awareness campaign to try. The campaign's called Child Cancer Smart. It's being led by CCLG. So it's to try and reduce the time between first symptoms and diagnosis.
Yeah.
And I've put some resources about that in the pack. So yeah, I think just kind of recapping on that, oncology nursing is fantastic. Scientific developments, making kinder treatments, improving surgical techniques, proton therapy, and earlier diagnosis. I think that's what what is coming for the future.
Brilliant. Lovely. Thank you very much for joining me this afternoon and having this chat. I've really enjoyed it, and I can't wait to share it with the rest of the student nurse network, and I'm sure they'll find it as insightful as I did. So thank you very much.
Good. Thanks for your time. Thanks for inviting me. It's yeah,
Thank
interesting
you.
request. All right, take care.
Thank you.